To welcome. Good morning and welcome to our webinar Beyond Diagnosis, Exploring Mental Health and Blood Cancer. And I'd like to welcome our guests, Dr. Charlotte Tottman and Nicole Blanche. And to start, the Leukemia Foundation acknowledges the traditional owners of the countries on which we live, study and work. And we acknowledge and respect the spiritual belief and strong connection to land, sea, culture and community of the owners. I'd like to pay deep respect to elders past and present who invite us to learn more about their rich culture and history, and extend a warm welcome to any Aboriginal or Torres Strait Islander people joining us today. So before we start, a couple of quick reminders. You're very welcome to add any comments or questions you have in the chat, and you can find the little chat bubble at the bottom of your screen. And this webinar is being recorded and will be available on our website and YouTube channel, so you can watch it at any time. We're going to hold the question and answer session at the end of the presentation, and we'll do our best to cover as many questions as possible, though we remind you that we may be unable to answer very specific or personal questions. So let's start. October marks Mental Health Awareness Month, and the theme this year is Let's Talk About It. And a blood cancer diagnosis can have a significant psychological impact on health and well-being. You might experience feelings of anxiety, low mood, or loss of control, or even fear. It's quite common and it can occur at any time after diagnosis. We acknowledge that this can be difficult to talk about and even harder to find the right support, especially if others are saying things like, but you're doing so well. So Let's Talk About It is a reminder that mental health is as important as physical health, and to be proactive in seeking information and help. And to discuss more about this topic, we have our two guest speakers. And first of all, it gives me great pleasure to introduce Nicole. Nicole is a 53-year-old single parent to 3 children, 11, 19 and 20. She's a dedicated runner and has completed marathons and managed to continue running throughout her treatment, which is amazing. In 2018, she was diagnosed with smouldering myeloma after a routine blood test while living and working overseas. She returned to Sydney in 2020 due to COVID, and shortly after, a scan showed numerous bony lesions in her pelvis, vertebrae, femurs and ribs, confirming that she'd progressed to active myeloma. This was followed by an autologous stem cell transplant in 2021. And in 2022, she separated from her husband of 25 years. Nicole relapsed earlier this year with an active lesion that broke a rib and has just completed 6 months of second-line treatment, and she's hoping to have another few years on maintenance before relapsing again. So it's quite the story. So I'm going to hand over to you, Nicole, to hear a little bit more. Thank you.
Thank you. Hi, everyone, and thanks to Jenny for the introduction and the opportunity to share my story about the psychological impact I've experienced since being diagnosed with myeloma. For me, a blood cancer has been so difficult and complicated to talk about. The staging system is different to the other cancers and what I knew, and the symptoms seem so unpredictable. In my case, I only show progressive disease or relapse with bone lesions. There's no blood markers or tests that can predict when that's going to happen. A doctor aptly explained it to me at diagnosis as it was secret bone marrow business. After my stem cell transplant, I only achieved a partial response, but I felt quite well and quickly returned to my routine of the kids and exercise and work. Shortly after transplant, though, I experienced viral infections, fevers needing emergency department visits, and I must have taken antivirals for COVID around 5 times. I felt really anxious and scared when my kids were sick, but I didn't show it. I was also worried about my numerous bone lesions that could progress at any time. I've noticed that there are just so many invisible psychological aspects of having blood cancer that are just really difficult for others to understand. And I thought about some examples. The first one was swimming in the ocean. It was something so easy and simple to do before diagnosis. But now I'm looking carefully into the waves to see how powerful they might be. I know that others with myeloma have had broken bones in the surf, so I feel so scared. I decide it's too risky and often I don't go in, but I'm still at the beach for others to see. I'm wearing my swimmers, I'm waving and smiling at the kids, looking happy and watching them from the sand. And then, as Jenny said, with running, I've always loved running and gym classes. And before diagnosis, was happy to push my body to the limit without a second thought. But now, after diagnosis, if I feel a pain in my rib, which I broke at relapse, or my leg, I stop and I'm trying to work out, is it a muscle? Is it bone? Is it just something else? And then my heart rate starts to go up. Sometimes it's like well over 160. And I consider, wait, my treatment has cardiac risks. It might be that. Or it's just extreme anxiety, worrying about breaking a bone that's not even broken. And those things just happen inside my head nearly every day. Others just see me going to my usual routine, gym, running, no difference on the outside. I can't even imagine saying out loud, oh, my heart rate's going too high. I could be exercising, or it's the treatment that carries the risk of a heart attack. It seems impossible to say out loud. And I'm also going to be brave and tell you that I use Google to learn about myeloma. It's led me down some really dark rabbit holes of worst case scenarios. I've found it really hard to find a balance between learning and hypervigilance. Admitting to family or friends that I was worried about what Dr. Google had told me and that I was feeling scared seemed way too hard. And the Dr. Google bit always seemed way too embarrassing to admit. I thought it would also be helpful today just to briefly mention the breakdown of my 25-year marriage that occurred after my diagnosis. The closest person who I expected to be there couldn't be. So it was a complete surprise who stepped in and out once I had cancer. Friends who I hadn't spoken to in years were suddenly there to help me and give me a hug when I needed one. Unfortunately, I didn't seek out help for my mental health until my marriage had broken down. But in retrospect, I wish I had have done earlier at diagnosis, because I just couldn't fully understand the psychological impact of a cancer diagnosis, especially blood cancer, myeloma, that I knew nothing about until I had that support. One last issue that I've experienced, which is strange to say out loud, is feeling like an imposter with blood cancer. After transplant, the treatment was very intensive at the transplant, but after that, it's often, for myeloma, it's often quick subcutaneous injections. It only lasts a few minutes, and I often I don't get any nausea, sometimes fatigue, the lovely Dex, but really with second line treatment, along with a clinical trial, the schedule was intense, but I really did feel well and active throughout. And I even ran a half marathon in the middle of it, which I was very proud of. Sharing with others what I saw as mild or no symptoms kind of often makes me uncomfortable. And sometimes it's so much easier not to even mention I have cancer. So that's it from me. I hope my story might help some of you feel a little less alone in your thoughts. And back to Jenny. Thank you.
Ah, Nicole, that's an extraordinary story. And I think there's a lot of people in the audience sending up little love hearts and amazement. And I think you've touched so many people with what you've said, with the rawness and the truthfulness of so many aspects of being invisible and being impossible to talk about, and even a little bit of that embarrassment of not quite knowing what's going on. So thank you for being so generous in sharing that. personal story. So now I'm going to hand over to Charlotte Tottman. Dr. Charlotte Tottman is a clinical psycho-oncologist, and she consults privately, providing psychological treatment for cancer-related distress. She works with cancer patients, their family members and carers at all stages of their cancer experience. Charlotte also works very closely with a lot of peak bodies such as Breast Cancer Network Australia. She's an editor for the Cancer Council of Australia and has strong links with the McGrath Foundation, Canteen, Ovarian Cancer Australia, and of course, LF. So I'm going to hand now to Charlotte for her presentation. Thank you.
Thanks, Jen. Bear with me, everybody, while I set up the screen sharing situation. Oh, doesn't want to do it now. What is going on? There we go. Right. Hopefully that's all working and everybody can see my slides. So I'm going to talk to you today about mental health in a blood cancer context. And as Jen said, I'm what's called a psycho-oncologist, which is just sexy language for a clinical psychologist who specialises in cancer-related distress. There aren't very many psycho-oncologists, and so I think it's important to just highlight that if you feel like you'd like some support with mental health in the cancer context, you don't need to try and find a psycho-oncologist. I mean, by all means try, but if you can't, then seeing a good general psychologist or a good clinical psychologist will still be really helpful. Because cancer is unfortunately so common everywhere, but in Australia we have, I think, in total, not just blood cancers, but all cancers, about 150,000 diagnoses a year. It does mean that every psychologist is probably going to have some experience with treating some people with cancer. So psycho-oncologist is great, but psychologists generally also excellent. I'm going to talk to you today from three perspectives: from the theory of psycho-oncology and the evidence base around that, from my clinical experience. I work in private practice and I do cancer work all day, every day. And also from my personal experience, I haven't had blood cancer, but in 2018, I was diagnosed with breast cancer and I've been through treatment for that, and I live with fear of recurrence every day. The first slide that I'm going to highlight is about the timeline of a cancer experience, and it's something that is, I think, under-addressed generally, which is not to criticise the medical profession. At the beginning of cancer treatment, on diagnosis, as most of you watching will really understand, it's usually pretty fast, and you're sort of thrown headlong pretty quickly into treatment decisions, and then treatment, and then managing side effects and lots of appointments. And the idea that this might have a long tail that includes a whole lot of psychological adjustment is not forecast. It's usually not mentioned. And it's not until you get through a lot of the beginning stages of treatment that you start to actually confront the realities of what this all means for your life and for your future, and the impact on things like your family and loved ones. So if we look at the slide, you see down in the bottom left-hand corner the moment of diagnosis, and then up as we follow the winding line, hospital-based treatment, which can last months to years, depending on the situation. And then post-treatment adjustment, which starts at the beginning, it starts at the end of hospital-based treatment, and it lasts at least 2 years and often a lot longer. And often I see people when they begin this post-treatment adjustment, and often what characterises their need to come and see someone like me is at the end of hospital-based treatment, they often fall off a bit of a psychological cliff, because up until then, they've been really focused, very reasonably and understandably, on coping with the rigours of treatment. And it's not until there's sort of a bit of a safe space where they can kind of down the medical treatment, if you like, and then start to really confront and reflect on the magnitude of everything they've been through and what that means for the next chapter of their life and the rest of their life. So post-treatment adjustment is a really big deal, and that's a lot of what I see in my clinical setting. which is what the next slide highlights, the two key psychological presentations, these are the ones I see most of, are anxiety and adjustment difficulties. Now, that's not to say that I don't see depression and other psychological presentations, but in the main, in general, I see mostly anxiety and adjustment difficulties. And the reason this makes sense is, broadly speaking, just to touch on both of those, is that anxiety is about the future. Depression is mostly about the past, about things that have happened that we wish we'd done differently or we wished hadn't happened. But anxiety is about worry about things that haven't happened yet. And so in a medical space, in a blood cancer space, that kind of makes sense, because as soon as we're diagnosed, we start worrying about what's going to happen next. We start worrying about the future, about whether the treatment's going to work, about whether I'm going to survive, about the impact on me, on my life, on my family. And so anxiety is kind of like a natural fit for a psychological response to a blood cancer diagnosis and treatment. One of the things that sets anxiety apart from almost all other mental health presentations is that it comes with a bunch of physiological symptoms. They're often called somatic symptoms. That's just technical language. But the physiological symptoms are many, and nobody gets away with none. So some people will experience, when they have an anxiety spike, some people will experience all of these symptoms that are on the slide at the moment. Some people will just have a few, but nobody has none of them. So just quickly going around the slide, if you get an anxiety spike, you will often feel like your brain's been hijacked, like you can't think straight, you can't make good decisions. And that's because the blood in your brain redistributes to other parts of your body, like your arms and legs, to get you ready for fight and flight. It's a primitive response. It's not necessarily all that helpful in the technological age that we live in now, but it is what happens. Your body heats up and sweats, your eyes widen, which you probably wouldn't notice happening. And the reason that happens is it's right back to the Stone Age times, where if you're on the plains of Africa and you're about to be attacked by another marauding tribe, your eyes widen as a way of you being able to see exit strategies on the landscape. So it's a primitive response, but it still happens. Our mouths get dry, your heart rate goes up, you often feel like your arms and legs tingle and tremble. Your bladder relaxes, which is why most public speakers need to rush to the loo before they get on stage. Your muscles tense. So a lot of people who have an anxiety spike will report in the aftermath that they feel quite exhausted, and that's because they have like a letdown response when their muscles relax. They don't realise how much energy they're holding when they're tense. Your stomach churns. Again, that's why sometimes you feel like you've got a loose bowel or you've got a funny tummy, like an exam tummy type of situation when you're anxious. Your breathing gets fast and shallow, and that means that you're getting more carbon dioxide than is good for you, and that makes you lightheaded and dizzy. So you can see that, like, anxiety does a whole bunch of stuff to us, and none of it's very pleasant. Anxiety is our internal burglar alarm, and it's got a bad reputation. Most people, when they hear about somebody being anxious, the first sort of instinctive response is like, well, we want to get rid of the anxiety. We want to get back to feeling not anxious. The truth is that our anxiety system is the thing that's there to keep us safe. And if we were to get rid of it, it would be a little bit like turning off the burglar alarm at home. And what happens if you do that? Well, then the burglars can get in. So we don't want to actually neutralise anxiety or remove it entirely. We want to get it to what I call Goldilocks anxiety. Just enough, not too much, not too little, just the right amount. And for a lot of people who are dealing with anxiety in the cancer space, it's like their anxiety system's just got dialed up a little bit too high. And so we just want to get it down into what we would call the normal range, rather than being kind of like on 24/7. As I mentioned before, the other presentation that we see very commonly in the blood cancer space is adjustment. And adjustment is just language that describes getting used to change. All adjustment is a time-based process. So the longer that you have to sit with something new, the more you adjust. The new stops being new with time and it becomes the familiar. And there are lots of adjustment processes one of them is grief and loss. And there is, in fact, quite a lot of grief and loss in the blood cancer space, because we have to adjust to not often being able to continue to do the things that we might always have been able to do. We might have to adjust to the loss of things like how we feel about ourselves and our sense of identity and sense of self, and that can be connected to body image. It could be connected to the loss of stamina and capacity. So adjustment is a really big part of any cancer experience. However, it is not linear. It would be really nice to think that when we start an adjustment process, that we just head in a positive direction in a really nice, organised way. But it isn't like that. And so you will see the slide at the moment. The top arrow is how we'd all like it to be, and the bottom squiggly arrow is actually how it is. In many respects, I'll talk about it in terms of 3 steps forward and 2 steps back, or 19 steps forward and 45 steps back. Is very much like that. And so people can feel quite defeated. They can feel demoralised. They can feel frustrated when their recovery is getting a bit of traction, and they're starting to feel like they're reclaiming life and starting to feel like, okay, I'm getting the hang of this. And then all of a sudden there's a setback, and it can feel very scary, because it can feel like, am I going to spiral back to how I have felt previously? And I know, it's almost like I've been in the bottom of a big black hole and I don't want to go back there. But starting to understand, and again, time helps with this, that you can appreciate over time that your recovery will have those setbacks, those moments where it feels like I'm not heading in the direction I want, but then, just like it goes backwards, it starts to go forwards again. So that was kind of a long introduction and a broad cover of the types of psychological presentations that I see. This is a list of a more specific set of experiences, and I'm going to touch on each of these today. Of course, we could sit here and talk about this for a month. I'm only going to be able to touch on them briefly. If there's more information that you want about this, you can certainly do some Google research about this relatively safely, unlike looking up the medical stuff that Nicole was mentioning earlier. On that point, I will just say Nicole's story was a fantastic reflection of exactly what I see in clinic all the time. What she highlighted, that story of going to the beach, was that absolute textbook combination of fear and adjustment, like not being able to do the swimming in the sea that she had previously been able to do so comfortably and confidently before, and the loss that comes with not being able to do that, but also the fact that other people looking at her would probably think, all good, she looks the same, she's at the beach doing that same stuff she used to in her bathers. And so that emotional isolation that comes in that space as well. Back to my list. So I'm going to cover fear of recurrence, fear of disease progression, which are similar but different, death anxiety, which is connected to both of those, body image issues, emotional isolation, post-treatment adjustment, which is all about quality of life and grief and loss, the impact on relationships, including sexuality and intimacy, a perspective shift that I see in just about every cancer patient that I treat after they've been through diagnosis and treatment, and survivor guilt. So fear of recurrence and fear of disease progression are kind of in the same family. And for the majority of people who go through a cancer experience, they do experience some level of this. For people who are living with fear of recurrence, it's very much about, will there be a recurrence and what might that be like? When might that happen? Fear of disease progression is for people who are living with advanced disease and who are fearful about how that might unfold and what that might look like for them in terms of their prognosis for the rest of their life. It can, the research studies around this show that up to 99% of people who've been through a cancer experience can have a degree of fear of recurrence. And what that tells us is that whilst that's pretty ghastly, it also means that it's kind of normal. It's that common. And I think about these types of anxiety responses as being extremely normal because it's part of our adaptive survival mechanism. We are meant to fear something that has the capacity to take our life or change the quality or quantity of our life. It's a little bit like, and this is a kind of an awful analogy, but it's a little bit like if you're in a war zone, you're meant to be scared. If you're in a domestic violence relationship, you are meant to be scared. Part of that fear response is what keeps you vigilant. It's what keeps you safe. But again, it is about how do we live with it in the Goldilocks kind of state so that it's not dialed up so high. Despite the number of people, the very high number of people who struggle with fear of recurrence and fear of disease progression, the vast majority experience it at a level that still allows them to be fully functional. I see a very, 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 very small proportion of people who have a debilitating level of fear of recurrence or fear of disease progression. And how that's reflected is that they are often seeing medical professionals almost on a weekly basis, where they are primarily looking for reassurance that they are still medically safe. Now, what that often means is that they are spending an awful lot of time, energy, and money on seeing medical specialists, often more than one, and often people they don't know well because they might have exhausted their medical team with their anxiety, and they are hoping to engineer scans or bloods that are not otherwise medically indicated. And so for those people, like, the fear of recurrence or the fear of disease progression is at a debilitating level where it affects the rest of their life. That is not the common experience. The common experience is that fear of recurrence or fear of disease progression, it's kind of like it sits in the back blocks of your brain, and every so often it will be triggered. And the 6 main triggers are, the biggest trigger is a physical symptom. So for any of us who have had a cancer diagnosis and treatment, and then we have a physical symptom, if it's a physical symptom that's reminiscent of what we might have experienced around the time of diagnosis, that's a pretty powerful trigger. But some people didn't have any symptoms. Sometimes they might have been diagnosed by an incidental finding. So sometimes not having had a symptom is also scary because it's like, well, there wasn't a clue. And so how can I then trust anything going forward? The other symptoms that are not as potent, the other triggers that are not as potent but are nevertheless there, are medical reviews. So anytime we've got a medical review, it's like we go back to being that person, that patient in that chair to see that doctor, and it usually brings back a flood of anxiety. If we have to, if we are aware of a friend or a family member who has been recently diagnosed or who has lost their life to blood cancer, but truthfully probably to any cancer or other major medical illness. Media stories are very powerful triggers, not even negative media stories. It can be any media story about cancer. Cancer anniversaries. So anytime that it might be the anniversary of diagnosis, it might be the anniversary of starting a particular treatment or ending a particular treatment. Anniversaries are disproportionately powerful. They cause us to pause and reflect and review and remember where we were like a year ago or 5 years ago or whatever. And it does bring up lots and lots of strong emotions. And the diagnosis itself is a trigger, because as soon as we are diagnosed, not only do we go into diagnosis shock usually, which wears off after a couple of weeks, but one of the first things we start to worry about is this going to come back, or is this going to progress to a point that it might take my life? So both of these things are, before I continue, I do an exercise in clinic where, and I've done this for myself, where I ask people to conceptualize their fear of recurrence or fear of disease progression, and I get them to consider it as an object. So I get them to ask themselves, how big is it, like relative to a car or a house? And then what color is it? And how heavy is it? And can I push it around? Is it transparent? And if I ran my hand over it, what texture would it be? And that might sound like a weird thing to do, but what it does is it takes a feeling and it turns it into a thing. My fear of recurrence is a silver, solid, heavy metal, roundish shape about the size of a fist. For anyone who watched Game of Thrones, it's like Jaime's fist, his artificial fist. And for me, when I think about my fear of recurrence, I can then visualize it as an object. And what that allows me to do is when I want to, I can set it aside. In my mind's eye, I can use visual imagery to set my fear aside. And that can be weirdly helpful. Uncertainty is a big part of living with the aftermath of a blood cancer diagnosis. Human beings don't do well with uncertainty. The familiar, the predictable, the known, the organised give us perceptions of control, and that makes us feel safe. Uncertainty is one of three things that makes anxiety rise. So anxiety rises with the unknown, the unfamiliar, and the uncertain. And that's why humanity struggled so much with the pandemic, because we suddenly were flung into a situation where we didn't know what was going to happen, and our leaders, the people that traditionally kept us safe and guided us, they didn't really know either. So one of the ways to cope with uncertainty, and this is easy to say, and it's not easy to do, and even if you do it, you might feel like, well, it's only helping a little bit, but a little bit is better than not at all, is to acknowledge the parts of your life that you can control and focus on those, and to acknowledge the parts of your life that you can't control and not spend too much time focused on those. So it's not about pretending that there are these things that you can't control and trying to ignore them. It's actually about acknowledging them, but then switching your attention to the things that you can control. And so that's why things like exercise and social connections and activities with purpose and meaning can be really helpful in this space, because they're things in your life that you can control. One of the other strategies that I recommend in dealing with fear of recurrence and fear of disease progression is to use it as a motivator, which sounds kind of weird, but when there's something that's so prevalent and that affects kind of everyone and that doesn't diminish with time, and that's what we know from the research about fear of recurrence and fear of disease progression, is it doesn't diminish with time. It sits in the back blocks of your brain and it gets spiked on occasion. Is if we can't get rid of it, then how can we use it in a positive way? How can we use it to our benefit? And so in two ways, and probably more, but in at least two ways, we can use it as a motivator. We can use it as a motivator to engage in healthy lifestyle behaviours. So things like staying as well and healthy as you can, you know, going to the gym or getting on the treadmill or going for a walk fairly often, and also to take care of things like nutrition and sleep. And if you look after your health and well-being, your risk of recurrence, your risk of progression will be lower, and therefore your anxiety or your fear around that will also be lower. So that's one way that you can use fear as a motivator. And the other thing that you can use it to do is to crack on and do the stuff that you want to do. I put a post up on Instagram last week or the week before, which was called Do the Thing, which is essentially like, if there are things you want to do and you've had a cancer diagnosis and you don't know what the future might hold for you, then don't wait, don't dither, don't prevaricate, do the thing. Both of those psychological experiences, fear of recurrence and fear of disease progression, do in fact relate to death anxiety. And death anxiety is actually incredibly common and incredibly normal and incredibly unpleasant. It is about that idea that my life could be shortened, my life could be taken away from me by something, by not anything that I chose to do. So I didn't bring this on, this has happened to me, and I don't know when and I don't know how. And that's a really big, fat anxiety. being able to acknowledge that and being able to, put words around it and say out loud to yourself and to people that matter that, I am actually really scared about what this might mean for my life is an important part of dealing with death anxiety. And again, it is something that's going to spike. I do say to my clients that when they talk about death anxiety, and often people will feel worried that, they're being unduly morbid or negative. And I hasten to reassure them that actually it's an incredibly normal response. But in terms of dealing with it, I frame it as it's a place to visit. You just don't want to spend too much time there. So if you feel like your thoughts are going to death and dying, it's like, okay, yep, been there. I can spend, a few minutes there every week, every few weeks, but I don't want to be marinating in that space all the time. The reason that it comes up is because before cancer diagnosis, the idea of death and dying for all humans is like an abstract concept. It's like this nebulous idea that just sort of sits out there, and you don't really have to pay it too much attention because it's not a concrete reality. But when we are diagnosed with blood cancer, that nebulous idea starts to become a possibility. So it goes from being right out there in your mind's eye to being kind of like front and center. And that's what spikes the death anxiety. All of these anxiety responses can, not always, but can lead to a panic experience. Panic is like a very narrow part of a wider umbrella of anxiety. And panic, for anyone who's had a panic attack, is a pretty nasty experience. It can feel like, and is often interpreted by your brain as impending doom, and it can feel like I might have a heart attack or I might pass out or have a stroke. It's usually characterised, when we unpick someone's panic experience, it's usually characterised by the misinterpretation of a physical symptom that's going to lead to a negative outcome right there and then. What often happens is that there's some sort of a trigger that often people don't even notice. They don't recognise what the trigger is. So they might be, say, in a shopping centre where it's really hot, and suddenly they feel quite kind of overwhelmed and claustrophobic, but they haven't really noticed that in the front part of their mind. And all of a sudden, they start to feel like they're shallow breathing and they can't catch their breath and their chest gets tight, and they start to feel like, oh God, I'm in real trouble here. I'm going to have a heart attack. Now, what happens to your anxiety system once you start thinking I'm going to have a heart attack? It kicks right in. And so then the thought that something bad is going to happen to me exacerbates the anxiety that was there before, and you get into this spiraling situation. And for most people who are in a panic situation, they really find it completely overwhelming. A lot of people will feel very teary, like almost like they will need to drop to the ground because the physiological stuff is so overpowering. The way to cope with panic, and this is very counterintuitive, is, if you can, is to not flee. The very strong response physiologically is to get the hell out of there, wherever you are. The problem with doing that is it sets up a belief loop that the only way I can cope with this overwhelming feeling is to get away from where I am now. Now, that's all very well, as long as you never have to go back to that place again. But if it's like your local shopping centre or your medical specialist's rooms or your mother-in-law's house, and you've got to keep going back there, then if you flee, it's going to make it much harder for you to go back there again. And the other thing that it sets up is that I can't cope with this physiological anxiety response, and that it's the driver and I don't have control of the situation. So what we recommend to people, and again, it's very hard to do, it's very easy to say, if you manage to do this once, however, you will feel quite empowered, is to get yourself somewhere where you can sit down. I would say lie down, but if you lie down in a public space, people will think something terrible is going on. So if you can sit down and keep your back straight and keep your lungs open as if they are your two big oxygen cylinders, and you slow your breathing right down and you wait out the panic. Now, most panic attacks, when I get people to think about how long they last, For most people, it's between about 5 and 20 minutes. And that sounds like a really long time when you're in a panic attack. But of course, in reality, 5 or 20 minutes is not, it's not ever. The other thing that waiting out a panic attack will teach you is that panic will rise. And then if you wait, it will dissipate. And if you get through a panic attack and realise that fleeing isn't necessary in order for you to survive a panic attack, the next time you get that same surge or the beginning of a panic attack, on some level, your brain will remember that, and it will mean that the next panic attack is slightly less, and each subsequent one will be easier to manage. That's just a very quick overview of panic. And for anyone who really is experiencing panic on a regular basis, I would certainly encourage you to seek out someone like me to dig into that a bit more. Body image concerns are another big part of the aftermath of blood cancer diagnosis and treatment. Appearance is really connected to our sense of self. And it is very common after treatment or during treatment for our appearance to change. Sometimes the changes can be temporary and sometimes they can be permanent. It can be things like hair, weight, skin, the way that we look. And our sense of self and our identity is so closely linked to our appearance that it can really distress us and disturb us psychologically when we don't look like who we always did. If you think about the years before you were diagnosed, in any one year, each of us would see ourselves in a reflective surface probably hundreds of thousands of times. And each time that happens, our brain takes, if you like, a little snapshot of our image and it puts it in a file labelled in our brain, labelled, this is what I look like. And then through cancer treatment, we might look in the reflected surface and the image that we see doesn't match all of those images in the file in our brain that says this is what I look like. So it sets up this thing called cognitive dissonance, which is where you're trying to hold two ideas in your head at the same time. So you've got this file in your brain with all of these images saying this is what I look like. And then you've got this reflection in the mirror that is what you look like now. And those two things don't match anymore. And that can be very destabilizing. And the other thing is that it can be really hard in terms of the impact in relationships or in our connections with people around us, because they are also sometimes struggling with the changes and people can be very clumsy in that space. So again, it's not just about how we might feel about ourselves, but some of that can be unfortunately reinforced by people around us. One of the things that sometimes happens is an avoidance response, which is where we stop looking at ourselves. We try and avoid the mirror. We don't want to see ourselves like naked or near naked. We don't want to confront the changes. Again, the recommendation that I make, which is very counterintuitive and people don't like, but it is in fact to look at yourself more often. I have a big scar from my double mastectomy across my chest. And one of the things I do every morning is I put my hands up above my head and I stand in front of my mirror in my bathroom naked and I look at my scar for about 5 seconds. And I've been doing that for years and it has helped my body image adjustment. Do I like everything that's happened to my body? Sure, no, definitely not. Am I more adjusted to it though? Absolutely yes. Emotional isolation is a really big part of a blood cancer experience. It's best described by the words, they just don't get it. And it's almost always about how people feel about their relationships, the people around them who love them. It's a weird thing because it happens even though we are surrounded by people that we absolutely know have got our backs, who support us, who love us, who are there to care for us. If you're on a desert island and you felt isolated, emotionally isolated, it kind of makes sense because it's like, well, there's no one here. Of course I feel isolated. But when you're surrounded by people who you know really care about you and you still feel isolated, that again can be very confusing. The thing that happens with emotional isolation is that we often feel disappointed and hurt. And this slide sets out the cycle that I commonly see. So if you look in the top right corner, when we feel emotionally vulnerable, we seek emotional support from others. I don't mean we go out with a flag and say, you know, I'm looking for emotional support, but your brain is looking for emotional support from other people. When we fail to locate or receive that emotional support, we emotionally withdraw. And where does that leave us? Feeling even more emotionally isolated. So we end up with more of what we didn't want. Now, that's nobody's fault. It's just what happens. And so then people, I think, sometimes worry and think, oh God, is Charlotte going to tell me that I then need to step back into that space? I took an emotional risk and it didn't go well. I don't want to step back into that emotional risky space again where I'm going to get hurt again. And absolutely, I'm not going to ask you to do that. In fact, if you go to the well and the well is empty, it doesn't make much sense to keep going to the well. But what it does mean is that it's a good idea to broaden your search, to identify people in your world who do get it, and to reach out and connect with those people. And that's where places like the Leukemia Foundation can be really valuable, because you can connect with other people who have been through or are going through something similar. Part of emotional isolation that a lot of people comment on is this concept called positive pressure, or what I call toxic positivity. And this is where loved ones or people around us can be coming from a really good place, but they will often be quite clumsy in their interpersonal interactions. And they might say things like, I just know you're going to be okay, or you're strong, you'll be fine, or just stay positive, or you're so lucky, you know, they caught it early, or it could have been worse. And the very common one, which is like, you look great. And it's a weird thing that, like, you know, on the one hand, I mean, who doesn't like to look good? Who doesn't like to look great? But when you're feeling as burdened and beaten as often you might be after a blood cancer diagnosis and treatment, when someone says you look great, it can feel incredibly invalidating, and it can make you feel really isolated, because it's like, well, you don't really understand what this is like for me. The reason that people say things like you look great is because human beings take in information through their eyes. If humans have got a choice between like what information they will receive as a primary source, it'll always be what they take in through their eyes. So if you look okay, people will assume that you are okay. And that is why often that they will make a clumsy statement. And sometimes that requires a gentle correction, which might be something along the lines of like, you know, thank you, and I'm glad that I do look okay, but like how I look on the outside is not necessarily how it feels on the inside. So it's just a gentle correction to make sure that they understand it's not as simple as that. Medical professionals can slip into that as well, and sometimes, like, in an effort to be reassuring or positive, can actually say things that we can misinterpret as part of that emotional isolation, and feel like people really just don't get what it's like to be me or what I'm going through. And that's where we want empathy. Empathy is where we have the feeling that the other person we're relating to gets it, where they understand what we're going through. And it's like a shorthand. It's like you don't have to persuade, you don't have to educate them about what you're going through, because they know it, because they're there too. It's like they can almost finish your sentences. And I think when there's real empathy, you can almost see it in the other person's eyes, and God, it's reassuring. I quite often say empathy is gold, and go where you can get it. Post-treatment adjustment, I mentioned before, is about getting used to the changes that happen as a result of blood cancer diagnosis and treatment. And there's a lot in this space, and it is different for everybody. It does often involve changes to your quality of life, and it does often involve feelings of grief and loss, of having to come to grips with the fact that things that we used to be able to do, parts of life that used to be very normal and common, have changed and may never go back to the way that they were before cancer. The sorts of changes that we might experience physically, stamina and capacity, changes in weight, hair and skin, psychological changes, rises in anxiety, difficulty with adjustment, and changes perhaps in our values and perspective, and cognitive changes, particularly after grueling treatment, where we feel like maybe we can't juggle mental balls the way that we used to. You know, I might have been able to kind of like keep 3 thoughts going in my head at once, and now I can just do one at a time. And things like our cognitive functions like memory, processing speed, and attention and concentration can all feel impaired and less than they were before diagnosis and treatment. And this stuff can affect all parts of life. There are 3 stages to adjustment: resistance, acknowledgement, and acceptance. Resistance is where we really are holding on to the idea that we want to get back to how it was before diagnosis and treatment. Acknowledgement is where we are starting to actually confront and acknowledge that there are real changes and that the changes are in many respects permanent. And acceptance is where it's not like we're saying, you know, I'm completely down with what's happened, or I'm glad that this ever happened, or I'm fully embracing blood cancer. It's more an acceptance that something bigger than me, that's outside my control, has in fact happened, and that I am now on board with the changes that go with that. The clues that you might be struggling with adjustment are if you feel frustrated or disappointed or feelings of failure. If those things are cropping up for you, then that's usually meaning that you're somewhere in the resistance and acknowledgement kind of space. People who have made it to the acceptance space have usually got past the frustration, disappointment, and failure, which is not to say that it doesn't spike from time to time, but that's generally how it works. This is a set of slides that just depicts post-treatment adjustment and the struggle. So the bottom line is your lifeline, and then there's the moment of diagnosis. Before cancer, there's your pre-cancer life, and after cancer, there's your post-cancer life. Your pre-cancer life is what we call your normal, and your post-cancer life is your new normal. A lot of people don't like the terminology new normal. You can call it whatever you like. Charlotte 2.0, the next version of me, it doesn't matter. It's just language that reflects the fact that it's not the same as how life was before cancer. In our pre-cancer life, we all had a bunch of expectation standards and behaviours that we would have used to great effect to get stuff done. And we take those expectation standards and behaviours without even realising, and we drag them into our post-cancer life. And unfortunately then, when we don't take account of the changes to our body, particularly around stamina and capacity, we can then feel frustrated, disappointed, and feelings of failure. And so starting to recognise, okay, am I holding on to that old pre-cancer normal, and am I then feeling frustrated because I can't do the stuff I used to be able to do, and I'm so desperate to get back there? The longer that you hold on to that, the more you're going to stay in that kind of stuck resistance space of adjustment. The more that we start to be able to go, okay, I'm going to do things differently. So it might be things very simply like, if it used to take you 3 hours to do a certain task, it's about adding on a third to a half and going, okay, it's now going to take me 4 or 4.5 hours to do the same task. Or if I used to be able to go out into the garden and do, 5 hours in the garden, now I might be able to do a half an hour and then have a break, and then do another half an hour and then have a break. So it's about adjusting what you used to do it differently, that's consistent or matching the new version of you. The impact on relationships is often profound, and Nicole's story certainly highlighted that today. One of the things that happens in a blood cancer diagnosis setting is that overnight, when a person who's in a relationship, in a committed relationship, when they're diagnosed, often what happens in that moment is their partner also becomes their carer. And nobody signs up for that. I mean, sure, we make marriage vows in the abstract, but it's not like you put in an application 3 months before diagnosis to say, gee, I'd like to be somebody's carer. It happens in a moment. And so that brings up this thing called dual relationships, which means that in a moment, you go from being husband and wife or partner and partner to being partner and partner and patient and carer. And that can set up lots of opportunity for misunderstanding, miscommunication, sometimes even resentment. So there's a whole bunch of stuff in that space that happens. Again, I could talk about it all day. The primary thing is to just understand that there is a big shift in relationships almost straight away. And it's a rare relationship where that wouldn't happen. Some people report something like cancer diagnosis and treatment can almost bring a relationship closer. But for a lot of people, it's another stressor. And I sometimes talk about a relationship as like a worn ceramic bowl that is much loved, but it's got a lot of tiny, tiny hairline cracks. And then imagine a flame being put underneath that bowl. The flame is the cancer diagnosis, and the flame heats up the bowl and it makes those cracks start to get bigger and crack apart. And that's what a lot of relationships feel through cancer diagnosis and treatment. Intolerance is one of the things that happens in relationships, and it's a very common psychological response to the stress that comes with a blood cancer diagnosis and treatment. A lot of people will report that they're much quicker to anger, their fuse is shorter, and that they can go to a 0 to 100, in a matter of microseconds, and quite often get bent out of shape about things that perhaps they wouldn't have before. This isn't easy to switch off, and a lot of people will also sort of be frustrated at the fact that it's happening and they kind of can't stop it. Again, acknowledging it is really important. Acknowledging it to yourself, acknowledging it to the people around you, and learning that if it's become a more frequent part of your life experience, then developing some strategies to limit the damage that it can cause. Intolerance is part of like an anger or frustration response. And I quite often will say to clients, it's okay to think angry thoughts and feel angry feelings. You just got to be careful what you do with it, because it's the behavioral stuff that causes problems in relationships. So sometimes learning like to take a time out, like to literally pause in the moment and just take yourself into the next room. There was a period in my post-cancer treatment experience where I was a witch. I was just a nightmare to live with. And one of the things I started to realise was that I couldn't stop my intolerance from boiling over, but when it would start to boil over, I would just take myself out of the space. I'd just go into another room and just calm down, and then re-enter, reset, restart. And I got quite good at that. One of the other things that is often affected in the relationship space is intimacy and sex. And again, big topic, often ignored. And I can only, give it a little bit of attention today. But the sorts of things that are impacted, I'm just going to go around this diagram and touch on them. So things like function issues. So parts of the body that would have worked in a certain way before that have been affected by treatment, that literally things don't work the way that they used to. Body image concerns, if we're worried about our body image and how we appear to ourselves and our partner, that can affect how we feel in terms of like how desirable we might feel. It can bring up feelings of insecurity. Practical changes. So often people might be doing things like temporarily sleeping in separate rooms. And so obviously if you're sleeping in separate rooms or separate beds, then intimacy and any sort of sexual activity is going to be much trickier. Stressors related to ill health, things like financial changes or work changes, the management of life around treatment can be really stressful. And we know for sure, particularly for women, that when the other parts of life are in flux, the idea that I can kind of relax enough to enjoy intimacy and sex is really tricky. Treatment effects, so things like hormone changes, stamina and capacity, pain, can all make a very big difference to how enthusiastic we might feel about getting close to someone. Role changes, what I was talking before about dual relationships. So if you are in a situation in a committed relationship where, you know, yes, it was partner and partner, and now it's partner and partner and patient and carer, that can be quite tricky because, you know, in one moment I'm dispensing medication and in the next moment we're talking about, like, are we going to like snuggle up together on the couch? That can be quite tricky in a relationship. So that's just a brief overview of how that can affect, how treatment can affect sexuality and intimacy. I have a lot of clients come in and start a session with me by saying, I want to talk about, you know, sex and how treatment's affected our sex life. And where we usually end up is we work backwards from there. In that, what I highlight is that in order to have good sex, you've got to have good intimacy. And in order to have good intimacy, you've got to have good communication. And one of the things that is very often evident is that the communication has dropped off. And often that is because of things like emotional isolation, where the cancer patient feels like maybe their partner, for all the love and care in the world, doesn't really understand or doesn't really get what it's like to go through what they've been through. So the beginning of improving a sex life or a sexual experience in cancer often begins with improving communication. Very quickly, I talk about improving sex also using the analogy of learning new dance steps. So for most people who've been in a committed relationship for some time and have had kind of a healthy sex life, you probably would be able to recognise that you've probably got a set of moves. You know, you've probably got about a dozen kind of like things that you pull out of the drawer and use as part of your sexual experience. Most people, I think, have half a dozen or 8 or so, something like that. And maybe they've got about another 3 or 4 that they use for special occasions. So what I say to people is, because of the effects of treatment, some of your moves probably now have to be retired. It's like some of them literally can't happen anymore. For example, too much information about me, but I don't have breasts anymore. So they were part of our foreplay experience. Breasts aren't there anymore, can't use them. So we've got to recognise that, acknowledge that that move is gone, and my husband and I needed to come up with a new dance step to include in our repertoire. So this takes trial and error, it takes communication, it takes a little bit of courage, but I know from my own personal experience that you can get there, but it won't do it by itself. The snow globe effect is an analogy I use that describes the shift in perspective that often happens after a cancer diagnosis. And I'm just going to read you through the slide because it describes it really beautifully. So imagine that a snow globe is your life. A cancer diagnosis shakes up your life, and all the little snowflakes inside the globe are your values and priorities. The cancer experience sets them all swirling, and when they settle, none of them lie exactly where they used to. So things have changed, values and priorities have shifted. Things that used to matter don't matter anymore, and things that didn't matter before often do matter now. There's an increased clarity about what is and isn't important to us. There is an increased willingness to live life consistent with that clarity. This is different for everybody, but I haven't had a client who hasn't experienced some of this snow globe effect in some way. For some people, it's a small thing. You know, they'll make decisions about saying no more often. For some people, it's a big thing. They'll decide to get out of a shitty relationship or to change a job. But it is weirdly, not that there's much that's good about a cancer experience, but weirdly, I do think that this is one of those times that it can be a bit liberating. It's almost a bit of a do-over or a second chance, a way of being able to go, do you know what? Just because I've behaved or made choices in my life up until now doesn't mean that I have to stick with that. I can change it now. I can do it differently, and I can live a new authentic life that works better for me. Survivor guilt is something that comes up. It's not something that everybody feels, but for those people that do feel it, they feel it pretty intensely. And it is the feeling often that's provoked when we become aware that someone that we might be close to, or it might even be just someone that we have heard about, has perhaps not survived, and we have. And it can bring up very uncomfortable feelings, like somehow it's wrong that I'm still here and that person isn't, that it's wrong that I'm here to enjoy my grandchildren and that person never will, those sorts of big fat feelings. I love this image. I just feel like it portrays the conflicted feelings that go with survivor guilt so beautifully. And on the subject of conflicted feelings, one of the reasons that survivor guilt is so tricky is because human beings like simple. We like one big feeling at a time. So the idea that I'm holding these two feelings, one that's like I'm kind of grateful and so happy to be here, and on the other hand, I feel so guilty and kind of wrong that I am, is like your brain doesn't know what to do with those feelings. The other thing that happens with things like survivor guilt is that we link things that are not necessarily connected. And this is one of the features of psychological distress more generally, is that when we're distressed, we quite often will connect things that are not otherwise connected. So we link my survival and the death of someone else, and we shackle them together. And then we feel bad because of that connection. So one of the strategies that I encourage my clients to attempt, and again, easy to say, not so easy to do, is to mentally unshackle the link. So to think about, okay, what are the two pieces that I'm putting together here, and do they really need to be linked together? Can I hold those two pieces but separately? And if I can hold them separately and say, I am genuinely grieving the loss of that person, I am so sad they are not here, but I am also genuinely able to hold the gratitude and the happiness that I still am without them being shackled together, because it's the shackle that brings up the conflicted feelings, that brings up the survivor guilt. So I've covered a whole bunch of things today that are all about the psychological presentations and experiences that come with blood cancer. And I guess it's a really good idea to talk about what might help. The 4 pillars of coping, very simply, these are 4 things that kind of help everyone all the time. Sleep. If I meet someone, if I'm treating someone newly and sleep quality is poor, then that's kind of one of the first things we want to get on top of, because when we have inadequate or poor quality sleep for too long, it's like acid dripping on your soul. It just eats away at everything, makes everything harder to cope with. So sleep is really important. Nutrition, eating well, good balanced diet, not too much of anything, not too little of anything. Exercise, I call it the silver bullet, and activities with purpose and meaning. So activities with purpose and meaning is a tricky one because it's different for everyone. You know, what's going to work for me is not necessarily going to work for other people. For some people, it might be, you know, being a member of a club or an organisation. For other people, it might be things like gardening. For other people, it might be creative endeavours. For other people, it might be writing a book. It could be anything, but it is about identifying what are the things that fill up your cup and making sure that you do a little bit of them fairly often. So something every week at least. Exercise is annoying because it helps everything. Yeah. Too easy to find a reason not to do it. But if you like my prescription often, and I do often say, it's like my clients come to see me for psychology and I send them away saying, I want you to do 15 minutes of exercise every day. And it's like, hang on a second, like, you know, what? But it is very helpful for everything. Helpful for mood, helpful for sleep, helpful for body image, helpful for managing treatment side effects. It really is the silver bullet. And it really doesn't matter what sort of exercise it is. Walking is like a superpower, and I do highly recommend walking, but it doesn't have to be that. Whole bunch of self-care strategies. This list could go on, but these are common ones. So interests and pastimes, again, activities with purpose and meaning. Meditation. Meditation is very powerful if you can get into doing it. It's a skill. You're not born knowing how to meditate, but if you can practice it and get good at it, you can learn to still your mind and bring down your arousal system, and that can be incredibly helpful for anxiety spikes. Sleep, as I mentioned, exercise, as I mentioned, social connections, which is staying connected with other people. We can often withdraw when we are anxious or feeling low mood, but staying connected with people, even in small doses, can be incredibly healthy. Any sort of psychological therapy can be with a psycho-oncologist or a psychologist, mental health nurse, even your GP. Healthy eating and limiting screen time. All of us probably spend too much time on screens, so a bit less of that, generally speaking, good for all of us. Just touching on Nicole's comment about Googling. I never tell people anymore not to Dr. Google because everybody does, but it is about understanding that you are a consumer of information, and if you can be an educated consumer and you can make good choices about which sources you get your information from, then you're going to protect yourself better. So peer-reviewed journal articles, government health websites, accredited organisations like Leukemia Foundation, where you're going to get good quality information that is specific to your situation, are going to be much safer than random sites or forums and blogs. Mental health supports, empathetic others, as I said before, go where the empathy is. Empathy is gold. Your GP, having a good GP is just so important. Leukemia Foundation, great resource, and a therapist. There are plenty of other free resources out there. The internet is, full of stuff, but it does take a discerning consumer sometimes to be able to sift the good from the bad. One of the resources that I was reminded of this week by my daughter is, and I know this might sound like an odd thing to say in a cancer context, is the Inside Out movies. They're movies that were made I think for a younger audience, but they are incredibly clever. And the second one has just been released, and they are about an animated way of discussing and highlighting emotional responses, psychological responses. Really powerful, really safe, and quite an easy way to increase your literacy around psychological responses. And now, questions.
Phenomenal presentation, as always, Charlotte. We've been so spoiled, and I can tell the audience are really enjoying the connection to the experience of you, Charlotte, both as a professional and as a cancer survivor, and also from Nicole. I would like to invite my colleague Linda Saunders to open the conversation up to the audience, and we're going to start with some of our pre-submitted questions. Charlotte's already answered a lot, and we'll do our very best to get through as many as we can. Thanks, Linda.
Thanks, Jen, and thanks, Charlotte and Nicole. Yes, we have covered a huge amount of content and really have covered off on a lot of the questions. But I will also, I'll invite both of you to respond as you desire. So we'll start with a fairly broad question, and I think it's a question that comes up for a lot of people when they're first diagnosed and then grapple with over the course of their diagnosis is, how do I make sense of a diagnosis, particularly when I've led a healthy life? How do I work through that, I guess it's a philosophical and perhaps meaning-making question. Charlotte, how do you respond to people who have those questions?
One of the first things that comes up, and I usually am keen to understand this in the assessment session when I first meet a new client, is the search for an explanation. It's one of the first kind of things that pops into people's heads once they kind of get over the initial kind of diagnosis shock. But it's like, how did this happen? And we search for an explanation because if we can find the cause, two things are possible. One is that if the cause is still current, so for example, if my breast cancer was caused because I drank an iced coffee every day and I stopped drinking iced coffee, then I'll feel a whole lot safer. Yeah. So it's like, if I can identify the cause and remove it, then I can feel safe. It's often not that simple, obviously, but that's why our brain is looking for the explanation. And the other thing is that if we can come up with an explanation, or someone can provide an explanation, it is sense making, and we can kind of like put the question and the answer in a box and put lid on the box and put the box away. And it's like, all right, I understand that now. I don't have to keep that live in my mind. And it can be very reassuring, you know, if there is a cause, but so often there isn't. And then we often will work through, well, what are your causal beliefs? And most people will have, even if they haven't figured it out yet, but I'll help them figure it out, is they'll have a causal belief. It might be something like genetics, it might be stress. In my case, both my parents died of cancer when I was in my 20s, and all 4 of my grandparents. So I was kind of like, well, we do cancer, you know, so like it's part of our family's, you know, skill set. For other people, it might be stress. For other people, it might be a belief that something in their life, like a traumatic event, has happened. And so being able to work through that. Where we often end up, however, is that in very many cases, the most likely explanation is random chance, which is not very satisfying, but working through the process can be helpful.
Great, thank you. It is a very common question that does come up. Talking about that new diagnosis phase, how can or why is mental health support not offered at diagnosis? So whether you're receiving treatment or not, and I'd love to get both Charlotte and Nicole your spin on this, because Nicole, I think you said on reflection you wish you'd had accessed that psychological support earlier on in your diagnosis. So I invite either of you to respond to that, or both.
Yeah, I'll start off, Charlotte, just from my experience, because the myeloma diagnosis I had wasn't even straightforward, because I was diagnosed with smouldering. So that was 2 years of being diagnosed with a cancer, but no treatment. And I think that probably confused me, because I was just, I might have a cancer. I do have a cancer, but my life is unchanged. So I'll just continue on and not address it. And I think that I felt that was the normal thing to do. There was no one really to say, have you ever talked to someone about it? It was just, this is what's happening. You're all good to go. And then the transition into active myeloma, maybe it was because I had 2 years of worrying about it, and then it was just, okay, it's happening. And it was just a lack of understanding and insight about mental health on my part. And hearing Charlotte talk today, it would have just helped me so greatly back in 2018.
Yep, I hear that a lot. And I think particularly for people who've kind of otherwise not had mental health struggles through their life, so they haven't traditionally been in touch with, a therapist, and they've probably coped pretty well with lots of other negative life events. It's like it's not on their radar. And if their medical team is not really across the mental health space either, then it often will sit there unaddressed until there's a crisis. And if I was 30 years younger, I'd probably start a campaign to make sure that on diagnosis of any cancer, that the patient is instantly given the option of some sort of mental health support, and that it should be an opt-out sort of system. So it's like it's an automatic part of your treatment plan, and that if you choose not to use it or activate it for a while, that's fine. But it shouldn't be that you have to crash and burn before you get access to someone. Unfortunately, that's not how it goes in Australia. It is very kind of hit and miss. I said at the outset, there aren't very many psycho-oncologists, which just perplexes me no end, because it's like there's so much work in the space that I operate in. But a lot of psychologists will say to me, like, I don't know how you can do cancer work. Like, isn't it just, really distressing? And I'm like, no, my clients don't want to die. My clients are like all about living, and they're incredibly motivated, and they're going through a really tough time. But, I get immense satisfaction out of the work that I do. So unfortunately, it is fairly common that mental health will not be an automatic offer at the outset.
Yep.
But for anyone that you know who might be newly diagnosed, I say to my referring oncologists and GPs now, like, suggest it at the front end, get a mental health care plan done. Even if you don't feel like you need support straight away, know that you might. So, get it in your frame of reference that, as this unfolds, it may be that stuff comes up that I need some help with. If there's someone you want to see, like someone like me, I have a long waiting list. I'm not easy to get into. People have cottoned on now, and so they will contact me early and say, I don't need you now. I'm about to start treatment. I don't need you now, but I'm probably going to need you in 6 or 9 months. So can I get on the list? And that works really well. And sometimes they get to the 6 or 9 month mark and they don't need me. They're okay. Sometimes they get there and they're like, right, I'm ready. I've done the physical and now I'm ready for the psychological. There is still some stigma around mental health stuff, and that's also a barrier. There's also the reality that living in regional and remote areas is hard to access mental health support, regardless of whether you're going through cancer or anything else. There are also other barriers. Accessing a psychologist isn't a cheap exercise, and we do say frequently that cancer makes you poor. So it's like, in addition to all the other things that I'm having to pay for, do I really have the resources to go and spend on things like a psychologist? And this is where things like today's webinar can be helpful, because, having access to a free resource and being able to maybe feel validated and make sense of a lot of stuff that you might be feeling can be a good proxy for then going to see someone.
Excellent. Yeah, thank you for that very thorough response. And Nicole, I'd like to respond to you. I think you said something about perhaps there was an element of lack of understanding around your mental health literacy. But, I also think it's incumbent upon us health professionals to be putting that option forward to our patients up front, because as people who work with people with blood cancer every day, we are aware of what that pathway is potentially going to be like. So I think there is a lot of work to do in the health professional space as well as around that. You've actually addressed one of my questions amongst that response, Charlotte, which was around how do we access what available options, and you talked to the mental health care plan, which is a really important support available, because some people do experience that support whilst they're in treatment, but that and I think you referred to fall off a psychological cliff after that treatment ends, and people find it much harder to access that same support, equivalent support in the community.
Yeah. Just on the mental health care plan, for anyone who's not across that, the mental health care plan is something that you can arrange via your GP. If you're going to get a mental health care plan, when you make the booking with your GP clinic, it's a really good idea to tell the admin staff that's what you're wanting, because they quite often like to book a double appointment. The process is usually that the GP will ask you a bunch of questions, they fill in a form, and then they give you a document or they fax to your psychologist the mental health care plan. And what that does is it gives you access to the Medicare rebate for psychology sessions, which you can't get without a mental health care plan. Yeah. And so it makes it more economically viable to go and see a psychologist. You don't have to have one to see a psychologist. You can pay the fee yourself, or you can use private health insurance. But for most people, using a mental health care plan is a really effective way of mitigating some of the cost.
Yeah, fantastic. Just want to talk to, there'll be many people watching today who live alone. So perhaps, you covered that concept, that emotional isolation, and you can be around a lot of people and still feel emotionally isolated. But what about people who actually do, really live alone, or have very limited support? What are some of the considerations for maintaining good mental health and well-being?
Yes. without wanting to suggest that people who live alone wouldn't have problems, what I will say at the outset is that if people have been living alone before they were diagnosed, there's a reasonable chance that they will have some already built-in strategies and behaviours that will be reasonably protective of themselves anyway. So what it makes me think of is, for example, my sister is a singleton. She always has been. And as a consequence of that, her friendship network is much broader than mine. I'm a married mother of 4. Yeah, I have a very small number of friends because I've got like quite a lot of action going on at home. My sister is different. She's got cats at home, excellent cats, but she has a much broader social network. So the first thing is to, I guess, maybe take stock of like what you do have and to not underestimate the value of that. One of the things that competent people struggle with is asking and receiving help. When they're competent, they're usually quite used to being independent, and singletons are often pretty good at being independent, which can then be a barrier to asking and receiving help. So I think it's also about, and this is where sometimes a therapist can be helpful in challenging some of those pre-cancer behaviours and preferences, is to go, okay, maybe I'm going to have to do this a bit differently, and I'm going to have to let go and be a bit vulnerable in that independent space, and maybe be willing to ask for and receive help in a way that perhaps wouldn't make me normally feel all that comfortable. And the third thing would be to be quite intentional and proactive about accessing probably quite that specific empathy with people who've been through something similar. So it's probably not the time to go out and go, I just need some new social contacts. It's really about going, I need to connect with people who are going to get it. So that if I've got limited personal resources, if I'm fatigued, if I'm nauseous, if I'm like struggling with treatment, I'm not going to have much to spend socially in connecting with people. So I've got to get maximum bang for my buck. So I need to connect with people who are going to give me quite a lot for a relatively small investment.
Yeah, great ideas. Nicole, did you want to add anything to that? You know, as a single mum, obviously your relationship status changed over the course of during your treatment. Is there anything you'd like to comment about that, and perhaps around that asking for help, or that sense of independence and wanting to maintain independence, but balancing it with needing perhaps the help and support around?
Yes, probably briefly. Also, the tricky area of adult children. My 20-year-old is the eldest, and really not wanting her to be involved in a burden of anything to do with my treatment or illness, and being able to ask for help through others, exactly as Charlotte had said. I found that extremely hard, coming out of a relationship with someone always there. And that, I think I said when I was speaking before, that there were friends that I had not really had a really close relationship with, and they just were there. And I was really surprised, and I didn't expect that either. And that's been a wonderful thing that happened for me.
Pardon me. Thanks, Nicole. I'm very mindful of time, so we might start to wrap up. I think one of the sort of key themes that has come out of today is around that the psychological aspect, and so much of it being a really invisible experience. It's an experience that happens, and I think, Nicole, you said it really succinctly. It's what goes on inside my head every day. And I wonder if you would like to perhaps leave us with a final message about, what's the one single thing that you do that helps you cope with those invisible aspects that of living with blood cancer.
Oh, that's a tricky one. But I think I'm going to reinforce what Charlotte said. For me, it's been exercise.
Yeah.
I don't know what it is. It's almost inexplicable. When I'm exercising, even though it seems hard, either the process of it or afterwards, I get a calmness, a clarity, a sense of achievement, and all of those things come together that allow me to just reset and then deal with whatever's coming up.
Yeah.
That's just my experience.
Thanks so much, Nicole. And Charlotte, for you?
Yes, I am 100% with Nicole. There are a few mechanisms, I think, that operate when we exercise. We get the endorphin kick if we're getting our blood pumping enough. But I think one of the other things is that we get a message coming back to ourselves that I am able, I am functional, I am strong, I can do, which when you think about it, on the back of like a blood cancer treatment experience where the messaging is, largely like, I'm feeling almost broken, then it's a very powerful antidote to that. And exercise can be quite meditative. So there's a lot of rhythm in exercise, and human beings like rhythm. And so I think that provides us with that ability to focus on just the present. And if you're in the present, if you're actively in the present, you can't be worrying about the future or ruminating about the past. So it is a really healthy space for your mind to be in. And I think the other thing it does do is it's like a circuit breaker. It allows you to just switch off from the stuff that might have been bothering you and have that reset experience so that you then restart the day or restart the week and feel like good and strong about yourself in that space.
Beautiful. I think that's a lovely place to end today. Jen, I'll get you to wrap up for today. Thank you so much, Charlotte and Nicole.
Thanks, everyone. I know this has been an absolute hit because we've had so many comments, we've had so many reactions to everybody sharing and questions and answers. So just a reminder that if you do need further information, you can check out the resources on our website. There's lots of old webinars there, some that Charlotte have done, some on meditation, some on exercise, a lot of the things we're talking about. And if you want to speak with someone, please call our support line, and that number is 1800 620 420. We're a very reputable organisation. Our information is up to date, it's researched, and if we haven't got the information, we'll find it or find someone who's got it for you. So thank you so much for joining us. It's very important that you're here with us. We couldn't do it without you. And if you have a chance to answer the survey that we'll email you tomorrow, we'd be really grateful because it helps us bring you more of what you need. So this draws our webinar to a close. Thank you all for your wholehearted participation, and we'll see you next time. Goodbye.